Hello, this is Dr. Michael Huggins, and I'm presenting to you today on medical issues in school-aged children in a post-pandemic world. The session description is here, and you've also read that in the literature that accompanied this, the NCEA symposium, so I won't repeat that here, but I would like you to pay attention to the outcomes. I want to synthesize information about select medical challenges, particularly chronic disease, that children face during the pandemic and as we come out of the pandemic. But I want also to call your attention to some of the policies and procedures that you may be faced with when we return back into classroom teaching. Finally, identify obstacles and some workarounds or some treatments that children receive medically that can cause some complications in the classroom, and how teachers and other instructional personnel can respond to those, particularly involving accommodations for those children. So this is a definition of chronic disease, and it impedes any condition that impedes attending school regularly, doing regular school work, being involved in a regular child's life with adolescent and childhood activities, but also requires frequent visits to medical professionals and medication and any particular equipment to manage a chronic disease. This is an important definition, and it's a standard that we accept to describe chronic disease. We differentiate between acute, generally less than 3 months, and chronic, something that is much more permanent, or at least extending beyond the 3-month window. These are the conditions that I want to talk about today: depression, asthma, anxiety disorders, and COVID-19. I chose these four specifically, the last one because it's so prominent in front of us, but also the first three because they are linked to the COVID-19 in a very special way. COVID-19 has impacted children in many ways, and I have included this hyperlink to a resource that you might find helpful. The health of children has been impacted not only physically, but psychologically. And the psychological effect is felt in depression and anxiety. The physical effects specifically focus on pulmonary and endocrine issues, diabetes and asthma. Both of those are of special concern when we're going through this pandemic and treating children or teaching children. And the questions that I want to focus on is, how does COVID-19 affect these other diseases? And how does this whole scenario affect accommodations that are offered to children? Finally, how is this going to affect policies and procedures of educational institutions, specifically private ones? The symptoms in children of COVID-19 remain the same as they've always been: fever or chills, cough, shortness of breath, or difficulty catching one's breath after any exertion. I note especially new loss of taste and smell, because I've seen that in a number of adolescents as well. And one that I'm thinking of has still not regained his full sense of smell, and it's been about 8 months since he had COVID-19. So these are the symptoms that we'll watch out for, particularly in children, and the source is below in the hyperlink. One of the ways this has really affected us is in the regular childhood immunizations. As you may know, most of our primary care sites were closed throughout the past year. We're just reopening now. I'm still seeing some people who come in with symptoms that we think might be COVID-19, but in most cases, we're seeing the regular primary care issues right now. However, the reality is that a lot of children did not receive their immunizations on time, so we're doing a lot of catch-up immunizations. But we're seeing an expanded hesitancy in vaccines and immunizations, and we're having a lot of questions from adults, parents, grandparents, about whether or not the child needs this vaccine. And by this vaccine, I'm talking about meningitis, hepatitis, that sort of thing, not just the COVID vaccine. Many parents rushed to have their children immunized with the Pfizer immunization as soon as it became approved for 12 years and older. But we are seeing pockets, particularly in the American Southeast, where this is not the case. And it is of special concern. But where that's affected us, it's in our childhood immunization schedule. So I've provided one here on the PowerPoint that you can see, and this includes the catch-up schedule. So we're doing a lot of catching up right now. The first condition, chronic condition that I'd like to present is on depression. In any 2-week period, the latest statistics we have from 2016 are about 7.6% of the population over age 12 suffer from diagnosed depression. And where we worry about this, particularly in younger folks, is that it's linked to possible suicide, at the very least, suicidal ideation. And as I've highlighted in yellow, between 10 and 24 years, suicide is the leading cause of death, followed pretty closely by accidents. But with suicide being so preventable much of the time, it needs to be on right in front of us as something we're concerned about with youth. There's a link on the PowerPoint slide here to the National Institutes of Health for suicide prevention. And then another hyperlink below to the CDC and their resources for suicide prevention in youth. Some of the signs and symptoms of depression, we may be looking for crying or withdrawal. Sometimes it's just silence. Sometimes children who are depressed simply sit in their seat and they're like many students in the middle of the bell curve. They don't demand our attention, and we don't find ourselves giving them a great deal of attention because it's demanded by others. And so children who are depressed tend to be quiet. They tend to withdraw from normal behavior, normal activities, normal interaction with their classmates and with adults. We can see that children like this sleeping in class. It isn't uncommon in depression to see the sleep cycle disturbed, either more or less. And adolescent girls who have migraine headaches, this can be really a devastating situation where sleep disturbance is included, because we know one of the triggers for migraine headaches is either too much sleep or too little sleep. And especially young ladies with migraine headaches need to have a sleep schedule that's pretty rigid, and depression can disturb that a great deal. Children who are depressed also have a hard time paying attention. They have a hard time processing information, because it requires a certain amount of interior reflection to take in new information, process it, and come to some conclusions about it. In depression, that becomes very difficult to do because our interior dialogue is so powerful. Children, as in adults, children can become stuck in conversations, interior conversations about their feelings, believing that no one cares, that they're not important, that their life has little to no significance. And these are powerful dismotivators for participation in the classroom and in learning. We will even see these children with behaviors including things such as cutting or refusal to eat or overeating. All these are common in adult populations, but they're common in children as well. Drugs are not a panacea for depression. Drugs are an important part to provide a quilt at either ends of the spectrum, so we don't bang against the edges. Life is a little more calm. However, we do have enough experience with children and adults on drugs by themselves over long periods of time to determine that without the participation of those individuals in therapy and counseling, the drugs are unlikely to be effective. So it's very important that children, particularly children who have a diagnosis of depression, severe depression or chronic depression, are involved in either cognitive behavioral therapy, interpersonal therapy, or perhaps even psychotherapy. We're always on the watch out for any threats or attempts at suicide. But more than anything else, I think the word is out by now, but it bears repeating. Asking an individual if that person is considering suicide or has considered suicide does not promote them to do it. We have good research that indicates that asking someone can provide an opportunity for that person to speak about it for the very first time. Suicide and suicidality are like mental health issues across the board. They are, individuals are disincentivized to speak about those things. And they feel as though they will be stigmatized if they do. So providing them an opportunity to have these conversations with adults who are significant in their lives, and that certainly includes teachers, but it can also be the persons who work in the lunchroom. It can be a principal, it can be a librarian, asking about these things. It's a very serious issue because we lose young people regularly to this scourge, and it can be prevented in most cases. So the assessment of depression, I've included two here, the BASC and the CDI-2, and I encourage you to look at those. These are instruments that can be used by individuals who can read and understand the directions. And in many cases, the instrument is completed not only by the individual, but by significant adults or parents who have care of that person. And so I encourage you to look at these too. You may already be familiar with the PHQ-9, the Patient Health Questionnaire 9. The 9th question asks specifically about suicidality or suicidal intent. That's an adult instrument. The children's instruments are the two that I mentioned below, and there's a hyperlink to a helpful resource about that. I encourage you to look at that. Things to watch in depression: pulling away from others, dissociation. Dissociation not only from other individuals, but significant events. Crying in class. Crying in class should always get our attention, and always does, but also a flat affect. By affect, I mean the emotional life of an individual. If nothing provides any visible reaction, either joy or sorrow, then that's a flat affect, or could be a flat affect, and that's something to watch out for. But also listening to other kids, listening to what children have to say about another child who may be talking to them about suicide, or even talking about harming him or herself. We do have a moment in the treatment of depression that we particularly are careful about, and that's when children have an intent for suicide, but simply don't have the energy or the wherewithal to do it. When they are treated successfully, and they may still have those feelings or the intent for suicide, now they feel better and they have the energy. They can marshal that energy for self-harm. So we're super careful about children who are on the treatment, who are starting to respond to treatment, and we pay special attention to them. Now, as a primary care provider working with a full range of family, and I do see a lot of kids, I can't always be the one who's there. I do contract with children about avoiding self-harm, promising me they'll either call me or they'll call an adult in their life. And that's been helpful. But when we are not around children all the time, and we start to see children who are responding positively to medication coming out of the depression, if that child has previously suggested that he or she would take their own life, then we need to be especially careful for that. Also, refusal to take medication. These medications do have side effects, and some of them are such that a child feels wrapped in a blanket and not really interactive with the world. If children are refusing to take their medication and that becomes known to the teacher, that needs to be reported to the family right away. This is an asthma action plan. This is one of many copies. When I received the one from the state of Washington, it also asks me what stage of asthma the student is in. In fact, I think I moved into asthma without seeing the slide. This is one that we're paying particular attention to now during the pandemic because of difficulty breathing being one of the cardinal signs of possible COVID that we need to look at. And this is the definition for asthma: a reversible chronic airway disease. And it's typified by breathlessness and wheezing. And roughly 7% of the population have been diagnosed with asthma. And they use different types of medications to manage that. Back to the asthma action plan, Typically in Washington State, where I live, we put on this sheet of paper the type of asthma, whether it's mild or mild to moderate, whether it's persistent or intermittent or exercise related. This one doesn't have that information, but it does have the green zone, yellow zone, and red zone. If a particular individual has asthma, the asthma action plan should always be on file in the school. If it's not, you need to contact the parents, please, and get a copy of this. If the parent doesn't have a copy of it, then we failed, and the medical provider needs to provide this. The green zone is when the patient or the child or adolescent is stable. Typically, no medications are required here in mild intermittent asthma. The yellow zone is typically where you would see a medication such as albuterol or Proventil. It was one of the Proventil HFA is one of the brand names. And we will use those as a get out of trouble drug. That's not going to keep you out of trouble because it's fast acting and short lived. Typically in patients and individuals who have significant asthma, they have a daily regular medication called the keep you out of trouble drug. Some of the medications you might remember or might have seen are some of the meter dose inhalers. The Advair Discus, for example, is one of them. But that is something that's used every day on a regular schedule to keep people out of trouble. If they have breakthrough asthma, then they will reach for the albuterol. So when I fill this out, I typically put medication would be albuterol sulfate, 90 micrograms per puff. How much to intake? Usually 2 to 4 puffs every 4 to 6 hours. And then I fill this out and I file this. After I sign it, I filed it with the school. And so the school has the copy of this. And this is important as an asthma action plan. No one with asthma should ever be without this plan. We know that asthma runs in families. It has a strong genetic component. And there's a word that we use to describe a setting where an individual is genetically predisposed toward inflammatory or immune reactions, and we call that atopy. So when we see patients who are children or adolescents with asthma, we should think, okay, could this possibly be in other children in the family as well? And we often find it. Triggers for asthma can be exercise. The classic trigger for exercise-induced asthma is leaving a warm, moist environment and going out into a cold, dry environment. Working out in the gym at wintertime, leaving to go walk to the car, being at a basketball game inside a school, and then in the wintertime, then leaving to go outside in cold, dry atmosphere. And individuals who are predisposed toward asthma can often have exercise-induced asthma in this situation. But there are also many other environmental factors, such as grass, pollen, dust, animal dander. In the asthma action plan, these should be written down. Drugs. We don't see children with asthma, with aspirin anymore, at least I hope we don't, because of the danger of death due to Rye syndrome. But we do see children who take nonsteroidal anti-inflammatory drugs, such as ibuprofen or Aleve. These can be triggers as well. Some children, and we're seeing more and more in my practice, of adolescents with high blood pressure. Now, the first line treatment for high blood pressure in adolescent is definitely not a beta blocker. Such as any of the beta blockers, they all end in LOL, metoprolol, timolol, things like that, carvedilol. We will not typically see these. I would never put an adolescent on this unless I had to, but beta blockers are known to be triggers for asthma attacks, food and allergies, as well as reflux disease. We have learned that GERD, or reflux disease, when the acid contents of the stomach spray up into the esophagus, that can be a big trigger for asthma. So we watch that very carefully in kids. And you may see this in adolescents, particularly those who are significantly overweight. This places a great deal of pressure on the esophagus. It's much more present when they're lying down, but it can be also when they're sitting at a desk. So an obese child or adolescent that has a coughing fit, very often we need to keep in mind that it can be reflux disease. And I'm not asking you or suggesting that you should diagnose people, but schools need to be aware of the drugs that children take and the medical conditions that they have. So The medical treatment, first line is albuterol. I mentioned that's called the get you out of trouble drug. Then inhaled corticosteroids, longer acting, taken regularly. By regularly, I mean every single day on a schedule. They're keep you out of trouble drugs. I've included here the importance of a spacer. When a child or an adolescent holds a meter dose inhaler up to his or her mouth and they squeeze it, it injects a spray from that device of medicine into the throat. It's very high volume, and much of the time it lands on the tongue or in the mucosa of the mouth and is not inhaled, because especially for younger kids, it's hard to synchronize breathing in with squeezing. The spacer itself allows, it's a chamber, and here as it is on this picture, this chamber allows it to reduce in velocity and remain in the chamber so it can be breathed in more normally. And this results in a tremendous increase in the actual medication making it to the lungs. Now, I have to write prescriptions for spacers. They don't come automatically and you can't buy them over the counter. And some medications have a spacer built in with them for pediatric population. Nonetheless, I'd recommend that if a child is having difficulty using a spacer, using a metered dose inhaler, and you observe the child using it without a spacer, it might be a good conversation to have with the parent or guardian about involving a spacer, because it makes the medication much more effective. Then we have a whole panoply of metered dose inhalers, MDIs. The thing that is often not included is a flow meter, a peak flow meter. This gives an objective score, a number, a volume of air, typically in 1 second. And we can use the peak flow meter to determine, and anyone actually can, the child can keep that in a book bag to determine whether or not the child is breathing at a level the child should be breathing at. And that information is also included on the asthma action plan. So for children who have asthma, they should, in my view, have a spacer to make the medication more effective. And the spacers are typically only for that type of metered dose inhaler. Some of the keep you out of trouble drugs, like the Advair discus, they don't use a spacer. They look like a big round disc, and we just breathe them in. It's more of a medication that goes in that way. But the peak flow meter is very effective for children who have asthma, who have a diagnosis of asthma and treatment for it. Complications. The use of albuterol, the get you out of trouble drug, more than several times a day or more than a certain number of times a week means that the asthma is not where we think it is. We might think it's mild. In fact, it might be moderate, and we might think it's intermittent when it's persistent. So when a teacher or a staff or administrator observes a child using albuterol, the get you out of trouble drug, too often, then the parents need to know about this. The other thing is that children who use albuterol can be very jittery in class. We can see their mood change. They can't sit still. They can't focus. That's because the albuterol drug itself has an effect on the lungs. It causes the bronchial passages to open up, but it also has a spillover effect on the heart, and that can result in fast heart rate, sometimes even skip beats. So children respond to that. Complications are school policies that keep these medications out of the hands of children. If a school policy requires all medication to be kept at the office, and that child has an asthma attack, of course, the albuterol sulfate, the get you out of trouble drug won't be available. That will be a problem. Lack of an asthma action plan. Every child with asthma should have one. It should be on file at the office, and it should be readily available to authorized individuals. Cost of drugs. Provenal as an albuterol brand, albuterol sulfate anyway, that metered dose inhaler over the last several years, the price has increased. It is terribly expensive, and that's a scandal. It's an ethical issue. Nonetheless, these drugs need to be carefully stored when children have them. For example, they can be in a book bag, but they shouldn't be out in the sun. And they definitely shouldn't be stored in a glove box of a car, because that denatures the medication and makes it useless when we need it. One of the terrible complications, the worst, is death. And children do die of asthma attacks. If they can't get their breath and they can't get the medication they need to reopen those bronchial passages, then they can die. Children have far less reserve than adults. So we might be able to hold our breath longer and have more oxygenated blood in our tissues to carry us through an emergency. Children will not have that same barrier, that same reserve. And that's why children can and do die of asthma. So we need to stay on top of this. Children who have asthma attacks, this can be traumatizing to other kids in class. Perhaps with the prevalence of a number of kids in school who have asthma and who've had asthma attacks in class, other children have seen it. But it is a frightening experience to see a child, for children to see a child who cannot catch his or her breath and is starving of oxygen because anxiety goes through the roof. It's called air hunger. And for an individual who can't breathe, anxiety is instant. For those around the person who cannot help, anxiety is also very high. Effective interventions by teachers, staff, and others. Be aware of the triggers and the diagnosis. The severity of the diagnosis should be known. Make sure the medications are available. Make sure you have a copy of the asthma action plan. Now, this is considered protected health information, so it cannot stay in the classroom. It needs to be someplace secure where no one else can see it. Breathing Buddies is a program that's recommended to have individuals very close by or sitting next to a person with asthma to notify the teacher or another responsible adult if they see something. They're called Breathing Buddies, and that really works well. Also, be able to summon help quickly if need be. And in the era of cell phones, that's really helpful. But in the old days, we had phones on the walls in the classrooms, and in your school, if you have a policy of no cell phones, a teacher should have a cell phone if any of the children in class may have a medical emergency, if it's even remotely possible. Anxiety disorders is the third condition that I'd like to discuss with you today, because anxiety disorders are prominent in children anyway, but with the closure of most schools and children remaining at home, isolated from their peers and not able to freely move about, anxiety has been increasing. And we're seeing it a lot in younger populations. We're even seeing it in adult populations. And so that should be no surprise at all. This is one of the most common diagnoses or conditions in children and adolescents. The prevalence is very high. Male to female to male rather, almost twice as many females have this condition as males. We see anxiety as the driver for a tremendous amount of primary care visits, close to 8 to 9% of them. Now, since mental health is stigmatized in this country and has been for a long, long time, individuals don't often share the information unless we ask for it. So we're particularly careful asking children about whether they're having depression and anxiety. Now, depression and anxiety run hand in hand. In fact, typically we see depression/anxiety as a common diagnosis because they are so prominently together. In alcohol and drug abuse, in females and males, we see it linked with anxiety. And the alcohol or drug abuse is an attempt by the individual to control that. That's their medication, their self-chosen medication. It correlates strongly and possibly with cigarette smoking. Cigarette is a prominent method for controlling anxiety. People don't realize that cigarette smoke actually increases the heart rate and triggers the autonomic nervous system, so the fight or flight response. So they continue to smoke. Nevertheless, that is one of the ways younger folks and older folks deal with anxiety. We don't know the effect of COVID-19 on diagnosis of anxiety in primary care or even specialty care. Those data are simply not available to us yet, but they will be soon. Nevertheless, we can be assured that individuals who've been isolated because of COVID-19 have not been able to take advantage of their normal compensatory activities, either with others or with hobbies or getting out and going shopping, just going around. We can expect that they have been, if they haven't found alternate ways of dealing with anxiety, that their anxiety is heightened. And I can tell you anecdotally that the number of people that I see who are on anxiety relieving medications, they've asked for them more often. They've asked for them more often. So the diagnosis, so the essentials of the diagnosis for anxiety are these: fear or anxiety that's excessive, or is persistent beyond what we would normally see in a person this age. We would expect coping mechanisms to develop. Individuals who have not can achieve or can have some significant anxiety. Fear or anxiety that's accompanied by behavioral disturbances. So we see children in class who won't sit still, who can't sit still, who may even have things such as artwork that is representative of interior struggles, frightening artwork that they're providing in class, or they're doing, completing in class, but also jittery behaviors, moving feet around, causing other children disturbances as well. And these can cause functional impairment, and they typically do as part of the diagnosis, and significant distress for the person who suffers these. The psychological aspects of it are these that are listed, and one of the most prominent ones is decrease in school performance. Children cannot focus to complete school activities, either in class or in homework. That has a negative effect on their own self-esteem, and they begin to believe that they are not as other children are. They're failures, that they're stupid, that they are requiring resources that are probably best given to other kids. And children with anxiety, anxiety disorder can give up in class. Paradoxically, at the same time, they can be very disturbing in class and cause a great deal of disruption in the classroom. So these are some of the psychological aspects of that condition. Psychomotor, again, restlessness and hyperactivity, but we can again see sleep disturbances in anxiety. Now, you can also see exhaustion in the classroom. We have a lot of children, even before the pandemic, were staying up late at night on the computer, playing either computer games or emailing or talking to people all over the world. And that interfered with their sleep. Then they were tired the next morning. Now what we're seeing for those children that are getting ready to go back to school, we're going to encounter ingrained habits over the last year. And these may be, some of these habits may very well be their attempts to control their own anxiety. When they return to the classroom, they will not have these same opportunities available. And that will show up as disturbances in the classroom. I would expect it to be that way. And so for teachers to be aware of a child who has a diagnosis of anxiety, to be on the guard for various types of manifestations in the classroom, specifically the psychomotor ones, the disturbing behaviors, the pacing in the classroom, not being able to sit and remain in a seat for a long time, not be able to focus on homework and in-class work, not being able to complete quizzes or exams on time, or not be able to do them at all. These are typical manifestations. Now, severe manifestation would be things like ritualistic behaviors. Having to go to the bathroom 6 or 8 or 10 or 12 times a day, washing one's hands habitually, twisting hair. I see that a lot. The parents complain about that a lot in class. Trichotillomania. We can see bald spots in girls and boys who have determined that that's a physical manifestation that allows them to physical activity rather that allows them to control their anxiety. So watch out for those things. And these are psychophysiologic. Palpitations, sweatiness, shortness of breath, and shortness of breath, of course, gets our attention now because of COVID-19, but also dry mouth, nausea, vomiting, headaches, stomach aches. These are all things that are listed as that are known to be psychophysiologic manifestations of an anxiety disorder. So we'll be on the lookout for these in our classrooms and in primary care for parents reporting what their teachers have told them. So this is a great opportunity to be in touch with parents proactively if you have a child coming back to the classroom with anxiety disorder. Not that you don't have everything else in the world on your plate, but ideally a classroom would not have 4 or 5 or 6 children in it with a diagnosis of anxiety disorder. So what we know is that cognitive behavioral therapy can be very effective along with medications. And these are some of the common medications that we see in the younger set for treatment of anxiety disorders. We, in the past, were guilty too long and too much of using the benzodiazepines, the Valium, the Librium, the Xanax, those types of drugs. We do not use those. I do not use those in primary care at all, particularly for anxiety disorders, except in the adults. In children, I do not. I rely on psychiatry or other methods before I would ever presume to put a young child on an anxiety relieving drug such as benzodiazepine, Xanax, that sort of thing. Those drugs are very habituating. Klonopin, clonazepam, drugs like that. They're highly habituating, and they're also very prone to diversion. So people will sell them if they don't need them themselves. So we don't often see those. We rarely see those. In the younger set, this is what you're going to see: Prozac, Celexa, Zoloft. I don't see much Wellbutrin, Remeron, or Effexor, and I don't use them in younger folks, but they are listed as possible drugs, so you may see them. Effective teacher interventions: find out what works at home. Find out in conversation with parents how they handle the anxiety at home. That may be quite effective in the classroom. It might not be, but it's certainly worth a try. Extra time for work. Anxiety is a positive feedback loop. Once it starts, it feeds on itself. And anything that can be done to interrupt that feedback, that positive feedback, will be effective in helping children. Find out what causes them. What are the triggers? Something could be something as simple as recess, feeling as though one is not safe in the playground. That can trigger an anxiety attack. Children do not always feel safe with older or bigger kids around them. Test anxiety is a huge one, and we see that persisting on into graduate school. So I don't think that's quite unusual for us to hear about. The youngest in the family. We have long known in family interventions that emotional expression is how younger children express what's going on in the family. So they will emote, and very often that's with crying, anxiety, tears, oppositional behaviors, defiance. So if there is something seriously wrong in the family, that can be expressed in the classroom. So this may be a good topic for conversation with parents. Not that you think something's wrong in the family, but asking about it. Sometimes asking questions takes a lot of power away. Homework assignments written down so children know exactly what's expected of them. Now, with many schools using computers and emails and parents having access to the children's homework, this is less of a problem. But still, children should always have, especially children with anxiety about schoolwork, should have clear directions on what to complete and how to do so. Frequent breaks. If these children can have breaks in class, this will be very helpful for them, particularly if you start to see sentinel events such as rapid breathing, breaking out in a sweat, frozen posture. That may be a time to invite that child to go back into a certain area and just sit quietly. And doesn't have to do anything, doesn't have to be something that we call attention to. It can be a breathing space, a freedom space that can rapidly de-escalate something that could get out of hand pretty quickly. Also be aware for children that are sleeping in class and that you know they're on medication. It could be that they're taking too much of it, or conversely, if they're not having any positive effect, it could be that they're getting rid of the medicine another way, not taking it, or perhaps worse, even giving it to some other child. The acute attack. This is where we see children freeze, jump up out of their chairs, pace, not able to incorporate external sensory information, such as the voice of a teacher, the voice of a classmate, a touch on the arm. They are locked into their own experience, and they're working toward a full-blown anxiety attack. So the most important thing at that point is to get attention, if you could possibly do so. One technique that works is co-breathing. Look at me, look at my eyes, and breathe with me. And you can do that with other children in class if you need to. Teachers are respected and cherished by most students. They're seen as authority figures, and a lot of kids look to their teachers for direction when they get into trouble. So, and when they're in the middle of an anxiety attack, having an adult say, breathe with me, look at me, breathe with me, because in anxiety attacks, very often we get tunnel vision. Our peripheral information is gone, and we focus on what's right in front of us. And if that is a trusted adult's face, that can be enormously relieving, much better than a drug. So teachers, again, need to know about this. And so, especially with students who are returning to the classroom, if they have a new diagnosis of anxiety disorder or they're a new student, this information needs to be shared. COVID-19 has affected the lives of everybody on this planet. What we know now is that the emergency use authorization for the Pfizer immunization extends down to 12 years and older. And so we are immunizing children as fast as we can for this with the Pfizer immunization. And we would expect, I expect in the next weeks to months to see other immunizations achieve that same activity in the younger individuals. We would like to see this extended even younger, but that's a safety issue. We need to establish that safety profile with data, and we simply don't have the data yet. Nonetheless, we are seeing the rise of the Delta variant, which originally we noticed out of India. It has taken hold at the time I'm presenting this in Missouri. It will spread, and it will affect predominantly those who have not yet been immunized for whatever reason. They don't want to be, or they've had one and not with second follow-up immunization, or they're hesitant, and that covers many people. But with the percentage of Americans now, or individuals in America who are now immunized, we are achieving a level of protection in many larger cities and communities, even some smaller communities. So we will see individuals who are at risk because they haven't received the immunization, more so from this Delta variant. And the CDC is watching this very closely. And the World Health Organization has called it a variant of concern. It is not going to be the last variant. From our perspective as providers, we're probably going to see COVID immunizations or vaccines become an annual thing, just like the influenza immunization is every year. But we are getting closer to that magic percentage where those of us who are immunized will provide protection for those of us in our midst who cannot be immunized or who, for whatever reason, have not received the immunization. The psychological effects on kids have yet to be determined, but there are a lot of studies that are occurring right now. And we know that children in isolation don't do well. Children who can't leave the house to go play outside, can't play with their classmates or their neighborhood friends, they can develop other not so healthy ways of coping. And these they're more easy to address these in the younger population than in older population, but they are realities and they will manifest themselves in the classroom. We may see children returning to the classroom who have never learned effective ways of interacting with other kids because they were too young. Now, we may see children who have forgotten that, or because of the influence of adults in their life, perhaps, or the media, look at others as being risks to them and don't want to interact with them and are anxious and scared about that. We'll see many emotional responses from children in school. The most important thing, though, is for us to make sure that as many children 12 years and older currently who can receive the immunization do receive it. That protects them. Now, we have no information, no data that indicates children are more at risk from the Delta variant or COVID, or that they give it to adults more often. But we do have a number of children, several hundred children in this nation who have died of COVID. And we don't want that to be repeated. We don't want any more children to become ill and die of that disease. As I mentioned, we don't have any data to indicate that children are more at risk for COVID or that they give it to other people more readily. But we do know that children have suffered disproportionately from isolation during the pandemic. So our goal is to get children and adults returned to normal rhythm of life as safely and as quickly as possible. If this can be done, then we will have achieved a tremendous a blow against this terrible pandemic. It's a miracle, I think, that we do have as many immunizations as we currently do, and we will likely have more, and they'll be more targeted. But the current situation is the presumption that children who have not been immunized are more dangerous appears to be wrong, or that adults are at risk from younger children, children younger than 12, who cannot be immunized at the current time. The risk that adults have more risk with these children. That appears not to be the case. We have no data to establish that, even though I continue to hear that from families and others. So the challenges to teachers, staff, and administration appear to me to be these. What do you do about children? What do you do about adults who refuse to be immunized or who cannot be? What do we do about children and adults who are immunocompromised? For whatever reason, either their immune system is not fully functional, or because of other medical conditions, they must take medication that reduces their immune system's ability to create antibodies to an immunization. What do we do about that? Can a private educational institution require its employees to receive a COVID-19 immunization? I think the answer to that is yes, but I defer to Sister Angie on this. Nonetheless, we're watching this very carefully because healthcare organizations, there's already been one ruling in favor of a healthcare organization that required all employees to receive the COVID-19 immunization. I don't know about schools. This is developing stuff for us, for all of us. Is it possible to establish a policy where 100% compliance is required? I don't know that that's possible. And I don't know that that's reasonable. Humans exist in different varieties, and not everyone, A, will mount the antibody response to the immunization, B, will mount it enough. Are we going to require antibody tests for all our employees? I don't think this is likely to happen. I don't think it's reasonable. But how do we determine what are effective policies? This is a developing conversation. The duty to care is well established in law. The standard exists with regard to COVID-19 as well. We have an obligation to provide care for those minors in our midst and under our supervision. That duty to care is clear, and it's a very important one. Institutional exceptions that allow a policy to be established, but then provide exceptions to the policy in a non-systematic way, or a way that's not been well thought out, are similar to handbooks that are beautifully put together by Sister Angie, but the school doesn't follow them and gets into trouble. When we publish a policy and we make exceptions to that policy, we go down a very dangerous road. So my suggestion would be that schools establish policies that are sound, that are well informed, but that are not ironclad. Doing so invites subterfuge and surreptitious documentation that we currently are fighting against with the CDC COVID-19 immunization card that's freely available on the internet, and people can download it, print it out, and just sign it themselves. But private educational entities do have the right to require compliance for immunizations, and I believe should do so. The second one is that there should be a standard established that focuses on protection of vulnerable persons, but also allows non-immunized persons a fair hearing. A fair hearing is important in any structure because it encourages individuals to come forward and speak their piece and gives them a sense that they will be heard fairly. And a fair hearing is all any of us could expect. Schools with immunosuppressed employees and students must establish sound policies, and those policies need to be enforced. A policy that isn't enforced is no policy at all. And then on the odd occasion when it is enforced, it's disproportionate enforcement, and that can lead to lawsuits. And that's something that organizations need to watch out for very carefully. Right now, we're seeing a number of states, Florida being one of them, that are enacting laws making a requirement for proof of COVID-19 immunization, making that proof illegal, making requirement of that proof illegal. I don't know if this is going to spread. I'm not sure what we're going to see how this is done. The danger, it seems to me right now, as I sit here recording this, and I'm thinking about Friday when I saw just a whole raft of patients, the most dangerous status to have right now is to be in the public, returning to regular life, and having made a choice not to take the COVID-19 immunization. Because we are seeing the spread of the variants, not just Delta, but other variants as well. And those of us who have accepted taking the immunization and believe that our bodies are sound enough to create antibodies to the COVID-19 virus, we can presume that we're protected. And those individuals who have not done that are those who are vulnerable. We have an obligation to care for them as well. The way to do that is to encourage and inform, but most of all, listen. People have all sorts of fears about taking a needle in their arm. It's not my favorite thing to do, I have to tell you, and I don't like giving them. I've been a nurse practitioner for almost a quarter of a century now, so for me to give anybody a shot is a dangerous proposition. I call those who do it every day. It's safer that way. Nonetheless, this is a really strange time to be alive, and people have so many things going through their minds. Probably the most important thing we can do is to be a charitable presence, a charitable listening presence. And I do a lot of reflective listening in the clinic room, in the exam rooms. And I find the reflective listening to be the most effective thing I have ever done with patients. The most effective. They hear what they're saying to me out of my mouth. And if I'm accurate, it may be the first time they've heard themselves say those words, because what a lot of people are hearing right now is judgment against them. That doesn't get us very far. I want to thank you for your patience, and I hope this has been informative. My email is below, and I look forward to hearing from any of you if I can answer any questions that you may still have, and I'd love to hear your suggestions as well. Thank you very much. Bye-bye.